Hi, everyone. Thank you for joining this Lancet webinar. I'm Ben Abbott. I'm executive editor at the Lancet, and I'm joined as a co-host today by my colleague Rupa Sarkar, who is editor-in-chief of the Lancet Digital Health. We'll be hearing today a bit about some opportunities for AI in cancer and oncology, and some of the challenges as well around its use. And in particular, we'll be taking a bit of a focus on health equity and some of the challenges around kind of developing and implementing AI in an equitable manner in cancer. First, some brief housekeeping points. I'll go through the agenda in a second, but we should have plenty of time for audience Q&A. So please ask your questions throughout the webinar in the question box, and we'll make sure we can get to as many of these as possible in the time we've got. There will be a link to an on-demand version of the webinar available after the event today. Once the webinar has ended, please do complete our quick feedback survey. It's really interesting. It's really useful for us to know kind of what works for you and what doesn't in terms of this format. Briefly on the agenda, we have three speakers who we've each asked to give a very brief talk to kind of introduce some key ideas. And then, as I said, we'll have plenty of time for Q&A at the end. Unfortunately, one of our speakers, Jakob Kather, does have to leave just over halfway through the webinar. So we will try and prioritize any burning questions you have for him. So please do send those in, as the speakers are speaking. To introduce you to our speakers, we have three brilliant speakers, all clinician scientists who are doing some really great work to kind of develop clinical AI and take AI into the clinic. So that's Jakob Kather, Karen Dembrouwer, and Judy Gichoya. And I will introduce each speaker as we go along now. So first up, we have Dr. Jakob Kather. Jakob is a full professor of medicine and computer science at the Technical University Dresden. His clinical specialism is in internal medicine and GI oncology. And within his research, Jakob has really been at the forefront of the field of AI for precision oncology for the last few years. And, is really leading work in terms of imaging and omic biomarkers, and also now large language models too. So I think we're going to hear a bit about.
Thank you very much. Thank you very much for putting together this excellent event, Ben and team. This is excellent. I'm Jakob, and I will give you a brief 5-minute overview about the capabilities of AI in oncology. So what is the problem that we are facing in oncology? One of the problems is that oncology is getting more complex. If we look at the guidelines for treating lung cancer, the ESMO guidelines, for example, in 2010, that's not so long ago, we had very limited options. There were only a certain number of chemotherapy drugs available, and that's about it, right? But in 2023, these guidelines were much more extensive. If you now look at the guidelines, how we treat a patient, for example, with lung cancer or any other cancer, then you can see that we find these huge decision trees. So we have to make many decisions to choose between many different types of treatments. The question is, how do we make these decisions? So one thing that can help us with this is biomarkers. A biomarker is something that you measure in cancer tissue or in cancer patients that helps you make the right treatment decisions and prescribe the right treatment. And the idea that we will discuss about that I would like to bring up today is that we can use artificial intelligence, AI methods, to extract such biomarkers. And artificial intelligence methods work really well on different types of data. What they have in common is that they need digital data, and they need a lot of data. So we have to use the data that's available at scale for every single patient. So I'm not talking about like spatial transcriptomics data or single cell data. No, we want really a real world data that's available at scale, such as pathology images, radiology images, natural language, or genomic data. how can we use AI to extract meaning from these data? Well, the methods that we have to our disposal have evolved very, very fast. This is just a very simplified timeline of maybe the last 5 years of the methods that we are using. The most common method is what we call single domain, single purpose models. So imagine you have an AI model that looks at a pathology slide and tells you this is cancer or this is not cancer, right? But then we have much more technical capabilities now. We have multimodal models by which we can put together, for example, genomic data plus pathology images and predict responses from both of these types of data. We have something that we call foundation models, which are large models that are trained on large unlabeled amounts of clinical data and can then be repurposed for many downstream models. And the latest addition to our toolbox is what we call generalist models. Think of ChatGPT or other large language models. These are AI models that can solve many problems potentially within one single model. I will give you just one example here. Let's go to the ChatGPT, which we all have access to. Of course, people are using this to ask oncology questions. For example, to ask which treatment options are available for a 60-year-old patient with lung cancer. So first of all, a disclaimer. You should not do this because this is not a medical device. And also we can never put any patient data into these cloud-based systems. But for academic purposes, let's look at this. The result that we get from a large language model here is very superficial. However, so it's correct, but it's not really helpful. However, if we give the model additional context, if we provide, for example, the guidelines for how to treat lung cancer, and then we ask the same question based on these guidelines, how would I treat a 60-year-old patient with this and this cancer? Well, then we might get a much more detailed and potentially more helpful response. So we have evaluated this in this recent publication where we evaluated the decision-making aids of large language models equipped with additional knowledge. And I think that this is how we will use and extend these large language models in the future. The bottom line is we all have to be aware what's out there, what is possible, and we have to use it in the right way in order to explore what this technology can do for us. With that, I'm already at the end of my very brief overview. I just want to show a photo of my team and research team in Dresden in Germany to point out one thing. We need interdisciplinary research to advance this field. For example, in my team, we have people with a medical background and a computer science background or engineering background, very diverse set of backgrounds. And I think we need a diverse set of perspectives to advance this field with these very rapidly evolving technologies. Thank you very much for listening, and I'm looking forward to discussing a bit later on.
Thank you very much, Jakob, for a brilliant overview of some of these emerging AI-based technologies, and also, we make a compelling case for the need for multidisciplinary research and research teams as well. So next up, we have Dr. Karin Den Brouwer. Karin is a senior consultant in breast imaging at Capio St. Göran Hospital in Sweden and a researcher at the Karolinska Institute. And Karin has been working primarily in AI's integration into breast cancer screening via mammography. And I think we're going to hear a bit about that story now from Karin. Thank you, Karin.
And thank you, Jacob, for your interesting presentation regarding capabilities of AI in oncology. It's a very interesting topic. And as Ben Abbott told us, I will speak about AI in breast cancer screening in Sweden. So as an introduction, I will tell you some words about the Swedish breast cancer program. It is free of charge, and all women between 40 and 74 years old are invited every 24 months. And since the program started, we've only been using one single modality, it's mammography, and density is not reported yet. So women are invited according to a predefined geographical uptake area. And in Sweden, there's a very small volume for private practice screening and private clinical breast examinations. So in the next slide, or in this slide, I will show you the workflow for AI integrated screening and the difference from now and earlier. So the woman comes to the screening, there we go, comes to the screening facility, and 4 images are generated, 2 views of each breast. And traditionally, 2 breast radiologists assess each examination independently. And if any one of them is flagging an examination for something suspicious, the examination will be discussed at a special meeting called consensus discussion. And in that meeting, at least 2 breast radiologists finally decide if the woman should be declared as healthy or recalled for further workup. So with the new AI integrated screening, one of the 2 readers has been replaced by a commercial AI algorithm at our hospital. And if either the AI algorithm or the human reader finds something suspicious, the examination will be discussed at the consensus discussion as usual. So how did we end up with AI as a human reader in the clinical workflow in Stockholm, Sweden at my hospital? So I will shortly tell you about our journey from research to clinical implementation. And in 2021 and 2022, we ran the first ever prospective clinical study, Screen Trust CAD, at my hospital in Stockholm, Sweden, and we included more than 55,000 women. The results were promising and showed that AI plus 1 reader find more cancer cases and recall less healthy women than 2 readers, which is the traditional way of working. And when AI was flagging an examination with and or without a radiologist, the PPV for cancer detection among recalled women was 10 times higher than when only human readers flagged an examination. Surprising. And after having these promising results, we started quite soon the process of implementing AI in the clinical workflow. And as per June 2023, we replaced 1 human reader with an AI algorithm, and that was very undramatic at our hospital. So now we've had AI integrated screening for more than 1 year, and I will shortly tell you about the results. We found promising results, and we can see that the false positive decreased from 89.6% to 78%. It's a decrease with 13%, and the PPV among recalled women increased from already quite high 16.9% to an even higher 22.1%. It's an increase with 31%. And then we can see the recall rates, they have decreased from quite low 2.8% to an even lower 2.5%. And the cancer detection rate, which is a very important number, has increased from 4.0 per 1,000 screened women to 5.5 per 1,000 screened women. That's an increase with 15%. So far our results are going in the right direction, but we have to be careful and analyze this regularly. So which equity considerations are we facing in this process then? So we want to have an AI algorithm that is trained on a diverse population where minorities are represented. And it's not always easy to get access to diverse datasets, and that is something we have to be aware of and take into account. The validation process is crucial. When you go to congresses and exhibitions and you see all companies having or demonstrating their own AI algorithms, they say that look how good this AI algorithm is performing in this data set, but that actually doesn't say really anything to me, because we need to know how the AI algorithm is working in the exact environment where it should be. So we really need robust validation data sets to determine disparities in different clinically available AI tools. And what about the access of AI then? For example, in Sweden, there are only a few hospitals working with AI integrated screening, and all women in screening age can decide where they want to be screened, although they are by default invited within a certain uptake area. And our experience is that women with more resources, they are more likely to find out where AI is integrated and where they can go for their screening, compared to women with lower socioeconomic status. And we have also noticed that there's a lower attendance in the screening program of women with lower socioeconomic status because of language, culture, and an inability to access the screening facility. And then we also have the radiological assessments. We know that AI can enable a uniform assessment of mammograms, even in remotely located, less staffed departments. And it's of importance that they can access AI integrated support as well as in more urban areas. And we also have to face the unconscious bias among radiologists in the consensus discussions, which are extremely important in this project. And we know that AI is flagging a different proportion of examinations than humans. And we need to take that into account, even though our human eyes, we only see what we see, but we don't see everything, that's for sure. So now I will come to my last slide. It's an example of the importance of how the AI model is built up and the subsequent training. It is from our study published in JAMA Oncology in 2020, comparing 3 AI algorithms, which were validated on one dataset with a subsequent different AIC curves. So thank you very much. That was all from me, and I'm looking forward to an interesting discussion.
Thank you, Karen. Really fantastic work, and a nice summary of some of the equity considerations around your work as well. So last but not least, we have Dr. Judy Gichoya. Judy is trained in informatics and interventional radiology. She's an associate professor at Emory University and co-leads the Healthcare AI Innovation and Translational Informatics Lab there. And I know Judy is putting a lot of thought into kind of AI and informatics in a global health context as well, and is thinking a lot about questions on health equity. And I think Judy will share her thoughts on AI for global oncology today. So thank you, Judy.
Yeah, thank you so much for the invitation. So I wanted to start off from sort of the estimates of mortality. And we see this map where we have different geographic regions with different colors for hopefully not too terrible for the people who may be colorblind. And I'm looking back home. Here is in Kenya, around here, and you can see sort of just a varied, you can at least appreciate the varied colors that show us the different incidence and mortality, and also the populations that live there. And so when I look at this slide, again, just honing in onto Kenya, you can see that while the world sort of has leading breast cancer, for example, from mortality in females from breast cancer, that it's really cervical cancer that is the leading cause of death. And I want to pause there, and for males, it's prostate cancer, is to remind us in the global context that really maybe we don't need AI, really, that vaccinations can make a big difference, can save lives. And so you'll see this sort of discourse from my presentation, where I challenge us to also think, where does AI bring the most return on investment, and what's the opportunity cost? And so we've seen a lot of enthusiasm around AI as the promise. We see even this promise of leapfrogging. When you think about mobile phones, as someone who actually grew up and saw the introduction of mobile phones, and just the success, that it's a way to be more productive. And you've even seen very good examples, from Ben and Karen. And, some of those things are, for example, patient engagement. Today, you don't need to rely on English as the only language where you can get information. You can improve access. You can ask questions. You can, for example, ask questions around, when should I get my screening? Where can I get screening? How do I plan for my screening, against my in the setting of recent, for example, vaccination, which can affect the lymph nodes in your axilla. But I want to stop and pause here, because when you think about these large language models, this is one form of AI that can be used, especially for patient engagement, that we see that the answers that are represent the majority of the opinion. Most of these global contexts don't have a very clear screening guideline. And so it's difficult to say, what guideline should you use? Should you use Sweden's guideline that says you should come every 2 years, or should you come every 5 years, or in the US, should you come every year? And those are different challenges. We see a big promise of AI for biomarkers. I think Jakob did a fantastic job about this. And especially, I'm a radiologist. I'm very enthusiastic about the use of medical imaging. Here is an example that's really just another example that AI can even find a new category of patient who's not going to respond to immune checkpoint inhibitors. But think about this. We will not have immunotherapy because it's so expensive for most of the population living in the global context. So why build this type of AI, even if it's very promising? And I'm not saying we shouldn't. I'm just saying that I want us to think and maybe have a discussion around this. So if you look at the trial data, and what ended up happening was that we could be able to figure out a subsequent group of people who will not respond. It's October. I hope the women in your life, your daughters, your moms, your wives, are getting screened. At least this is a big breast cancer awareness month this month. We know we screen most of the places using mammograms, and this can be very dense breasts, which hide breast cancer. And we see AI can actually not just help as a second reader, but can help as to tell you the risk of breast cancer in the next 3 and 5 years, and can do so with relying only on just the images. The existing clinical tools require a lot of information that even for myself would not be available for me to get an accurate prediction. And they tend to work different across different ethnicities. I know that not everyone in the world captures this information, but we see the AI tools performing better for people who historically have a lot of disparities. But it's not all rosy. I mentioned around the challenges of LLMs. We see that, for example, in this work we did for recommending what are the top differential diagnoses for young Black men who have upper respiratory tract infections, and it turns out that the LLMs think it's HIV, so encoding historical biases that have pervaded in our medical literature. We see a lot of enthusiasm for interacting with patients and chatbots, but they don't always work. We don't even have the legal framework that's necessary for us to be able to monitor and really have recourse when these make mistakes. We know that models learn a lot of the patterns that are there. I always show this in the global context because most of the studies, when I go back home, are mainly abnormal studies. It's late stage disease, and so they tend to be very different from more other the global north, where those tend to be normal studies. And so it's very difficult to translate AI across different settings. And even with AI, we still find an advanced treatment, we still find disparities where we see Black women tend to have still worse outcomes. And it is a cascade effect from who gets screening and to who gets treatment. And so just fixing one problem is not going to end up saving our lives. Finally, I want to say that, this is me spending time with Dr. Ivan Rukundo and the Rwanda team introducing interventional radiology where we're treating a patient with hepatocellular carcinoma. It's posted with permission. And this reminds me that there's always an opportunity cost. So what after you get AI diagnosis? Can we treat? Do we have the necessary resources? And where are we diverting resources when we spend all this amount of money on AI? I'm very enthusiastic about AI. I do develop AI, but I want to challenge us to think about what's the lowest hanging fruit, what's the opportunity cost, how do we regulate? Will we require FDA or the CE mark to be applied for regulation? Who's going to approve it, and what's the necessary infrastructure that is there? Who's going to build it, and then so what after AI? I look forward to a discussion around this.
Thank you, Judy. Thank you, Karen and Jakob, for fantastic presentations. And we have a lot of questions already in the chat, but please keep them coming. We hope to try and get through as many of your audience questions as we can. We've covered a lot of topics from Jakob starting us off with the need for data at scale for AI models, the evolution of AI models into these new generalist models. We went to Karen, who talked about an incredible screening and real world experiment with AI showing impact on clinicians and hopefully patients, and a really nice overview from Judy about the difficulties of translating AI research to different regions and really what are we trying to achieve with AI. So with all that in mind, I wanted to maybe start with one of the hottest topics of the past year, and that would be large language models that both Jakob and Judy have touched on. And we have quite a few questions about these. So maybe we could start with Jakob. What do you think are the equity considerations with your work on precision oncology, and how do you perceive some of the issues that Karen and Judy have raised in the work that you do regarding LLMs and these generalist AI models that you mentioned?
Yes, thank you so much, Rupa, for this important question. And I can only support what was said, that these models exhibit horrible biases sometimes, and they do not just reproduce biases in the training set, but we know instances where they even amplify these biases, right? So they're making things worse, and we definitely need to be aware of this, and we need to, of course, mitigate it. Part of that is fixing the underlying data, and part of it is making sure that the tech is behaving correctly given the underlying data. And now, however, on the other side, an aspect where these models are quite equitable is in the access to them, right? I mean, even the commercial models, you can access them on your phone. Everybody on the planet can access them. Some of them are for free. You can there's even an open source environment where you can download these models to your computer, like the Llama 3.2 model, which runs on my MacBook Air locally without internet, without a cloud provider, and it encodes a lot of humanity's knowledge, and I think that's incredible. So these are exciting tools, but we have to do some homework to really preserve and enhance the equity.
You talk about LLM applications that are not being used in the clinic at the moment, but you've tested a few for understanding patient responses, understanding diagnostics, for example, and patient notes. What do you think are the privacy protections, and what needs to be considered when using these tools in a clinical setting? Maybe that question could go to both Jakob and Judy as well. So maybe Jakob first.
Thank you. I can just say it very clearly: never take any patient data or any other personal data and upload it to ChatGPT. This is in Europe. This is not allowed due to the GDPR, and it's not. Don't do this anywhere. When we in my research team work with large language models that we apply to patient data, we use local models. Again, we download open access models. We run it on our computer infrastructure to make sure no data leaves the premise. There are also, of course, cloud providers who offer these models and promise to ensure that the data stays within a certain environment, etc. So these are options, but we have to be mindful of that.
So Judy, do you have anything to add?
Yeah, so I think, we have to, we're seeing a big change, and that change, one, is because we have these generative AI models that are making us say, maybe we need to slow down and think about when should we apply it. But on the other hand, we also have I think Jakob and Karen can say how difficult, how long it takes to deploy and really even test, even just do an external validation in the healthcare space, right? So we're in this tension where we're saying, if you think about the deep learning area, we're saying we're not adopting AI fast enough, right? But now with the generative AI, we're like, oh, maybe we need to take a pause. And so I think a few things to think about translation. One is that maybe that these models are not necessarily going to be used in the context of healthcare, where we are, it's going to be direct marketing to consumers, which is what we're saying, and what Jakob is saying, that I can run this on my computer. I don't need even internet to run it, and I can ask it even in the middle of the night when I'm tired or something else, when you don't have access, right? And so that's a reality we have to face, whether it's the providers. Just because the providers are not putting the data in does not mean the consumers or the patients are not going to engage with this model. And so I think when it comes to that direct to consumer marketing, and there's a lot of enthusiasm from the big tech companies to try and push this as a way to get entry into healthcare, I think that ship has sailed, and we just have to really do a lot of patient education and advocacy for that. But on the other hand, when it comes to, like the work Karen is doing in the hospital, that's tough one, because you have to integrate with some form. You can have a lot of automation bias when you use these models. They can make the doctor lazy, and it also depends, right? So for example, some people are saying that we should use this autonomously. So maybe just read the normal mammograms for breast cancer screening and leave the abnormal studies to the doctors, so that we don't really know what are the human factors that are necessary for successful translation. And also the metrics that come from the developer are very different from when you are using this in the real world settings. So like if I was a radiologist in Sweden and I had this AI tool, I would like to know when the AI is right, is usually right for our population or wrong? Because that's the question you ask your friend who you work with, like, oh, maybe just look at this case. What do you think? And that's how I would want to use the AI system, more than, just this random, but we don't have the infrastructure that allows us to figure out what's an optimum human partnership. So a long answer to say it's complex. With generative AI, we're saying, the cat is out of the bag. We need to slow down, but on the more traditional, but not the traditional sense of the way we think about computer, the machine learning models, we're saying we're not adopting fast enough, and we really don't know how to make sure that we have an optimum partnership for success.
Wow.
Beautiful summary. I just wanted to take this to Karen. You mentioned Judy had this experiment where AI has been integrated with clinicians in Sweden. Can you tell us a bit about how you educated clinicians and how that could be applied to other settings like LLM in clinical settings?
We've always had a very heavy workload, and when I said now we're going to have this study, we will have triple reading, AI will be a reader, so come on, we have to do this. They said, oh, Karen, don't push us too hard. We're already having a high workload, but we started off, and in the beginning, it was a little bit tough, but then we saw cases where AI found cancers, and we didn't really. We missed it, the humans. And then we got more humble, and so it was really a process for us to accept AI in the clinical workflow. And then when we closed the study, we had an option to not use AI or to continue. And we are 11 breast radiologists, and we all said that, we want to continue. It gives us extra information. So when we started off replacing one reader with AI, it was really undramatic because we were already used to the product and how it worked. But I would say if you would start using AI at a hospital right off, you really should get to know the algorithm, know how it works, and know and get the ground truth out of the cases, to see how it works, because we know that in the beginning we are a little bit insecure, and I think thanks to the study we could run it sharply in June 2023.
Yeah, brilliant, Karen, thank you. And I think we'll come back to some more questions on your program in a second.
Yeah.
While we've got Jakob with us, I want to ask some specific questions that have come in for you just in the last couple of minutes we've got with you. You talked about this, the context-aware use of, the in-context learning with LLMs. and someone has asked, what context could you give other than kind of clinical guidelines? What do you envisage? What other kinds of context do you envisage providing to these models? And then a second question is, you briefly mentioned that the importance of prompting these models correctly. Do you foresee a world where clinicians must be trained on prompt engineering to get the best out of large language models?
Thank you very much. So regarding the first question on the context, you can give basically any context to the model. I think the important thing is that you give some context. So you should not use ChatGPT and assume it knows everything and it's up to date with its knowledge, because it's not. If you ask it what's the right treatment for this and this disease, you will not get an up-to-date answer, because it's not. This was not in the training data. However, whenever you have a question, you could give relevant context. You could give the guidelines or any papers that you're interested in, or even your own notes or whatever, and then ask, based on this context, what is the answer that you can give to my question? And I think if you use the models like this, what we have seen is you reduce hallucinations, you reduce other problems that these models have when they give you a very generic response. So, and that's already a type of prompt engineering, like using these models to extract information from the context that you provide to them, which works very well now. Regarding the prompt engineering, I think that medical doctors are already good prompt engineers, because the essence of prompt engineering is that you're just specific in the information that you're communicating. And I think that's a big part of medical education. For example, when you transfer a patient to the doctor from the night shift or whatever, that you transmit all of the relevant information. I would just advise everybody to interact in the same way with really dense and comprehensive information with these large language models. But of course, what we need is AI literacy among doctors, so that they can tell the hype from the substance, and they can really, when a patient comes with a specific question, or even a patient comes and says, "Hey, I asked ChatGPT about this, and this is what I got," they can give a meaningful response.
Thank you. That was a fantastic answer, Jakob. I think we have one final question before you leave, and this is about LLMs are a reflection of the systemic injustices inherent in society, and but generalized AI offers unprecedented access to information. So with the inequities that arise from our unconscious biases and historical behaviors, do you see that these AI models can be an opportunity to highlight some of the inequities present? I think Jakob and maybe Judy can also speak to this, but Jakob, please go ahead before you have to go.
Yes, I do think that large language models can help us identify these biases, but I think ultimately the society and we have to accept and acknowledge these biases, and accept and acknowledge that our own perception is biased, and that there might be other people who have a different perception, and that is equally valid. And so LLMs will unfortunately not solve these problems forever. It's really us as humans and the society who has to work on this. Hopefully LLMs will not make it worse, and hopefully we will use LLMs to accelerate this, but the actual homework we have to do ourselves.
Thanks for your time today.
Yeah, I would agree with what Jakob said. We need to, if you think about with the data, right, the text that is consumed by these models, right, most of the work that's published is not from, some of this global region. So there's no way that your work is represented. And like Jakob said, then you have hallucinations. It doesn't say, I don't know, it just guesses. So that's the big challenge. And a lot of people are working on this now to try and control the predictions.
Thank you, Judy. Yeah, so Jakob has to drop off now. Thank you very much for your time. We're really grateful. And we'll continue the Q&A with Judy and Karen. Please keep the questions coming. We're having lots come in, which is brilliant. And it's just working out how to ask them in the right order. I want to move to Karen. There's some really interesting questions coming in on your AI-based system for breast screening. People are asking, were you able to detect cancers earlier with AI? And has AI's integration in screening affected the level or the number of unnecessary biopsies and surgery at all?
Well, very good questions. So we are actually right now analyzing the interval cancers from the study. We're collecting the data right now. And in June 2025, we will start analyzing the interval cancers from the clinical implementation. And I can just say that now we can also manually send the examinations to the AI algorithm. And when we work clinically with women coming with a suspicious interval cancer or a clinical detected cancer, we usually send her prior images to the algorithm, and in quite many cases we can see that the AI algorithm highlighted the same area where the diagnosed cancer arose, but then it comes to the score, the threshold, which is another interesting discussion, might not have been reached. So, but this is something we will look into, of course. And then the second question was about
unnecessary, whether you're preventing unnecessary biopsies and surgery at all.
Yes, that is very interesting. What I didn't tell you about the results from the study is that we also analyzed the AI-only track. And this was most surprising from the study, is that if AI would act as an own reader, no radiologist at all involved, AI only recall almost half of the women compared to 2 readers and AI plus 1 reader, which means that we also could avoid half, 50% of unnecessary biopsies. So we could make women less worried, which is really an important topic, and as well as save money because of unnecessary biopsies. That is a track that is we're doing some research upon, and other groups as well. The AI-only track, I think we're not there yet. Might be something for the future for a proportion of examinations. We'll see.
And that's really really interesting. And do you talk to patients about AI in the clinic and about how AI is being used in your workflows? You mentioned, yes. You mentioned it was kind of difficult for clinicians to trust AI in breast cancer screening. What about patients? Do they trust it? Do they want to know more about how it's used? And kind of what's your view on all that?
Since we are 3 breast centers in the Stockholm region in Sweden, and we are the only one using AIs, and since we've had some publicity about this, the more, so to say, aware women, they know that at our hospital we run AI integrated screening, and they have the right to be screened wherever they want. So they're running to us and saying, oh hi, I don't belong to you, but really I want to have my breast screened with AI. Can I switch to your hospital? And of course they can. So, but then we have also an uptake area with a lower socioeconomic status, and they are not calling us in that way because of cultural disparities and language problems, and maybe an inability to even get to the screening facility. So that's our experience right now.
I mean, that ties in with the next question that someone has asked. What is being done to reach women from resource poor, minority ethnic backgrounds for breast cancer screening? Is there a potential lack of information about AI being a potential barrier to accessing breast cancer screening in these groups? So what kind of initiatives are underway there, I suppose?
Yes, just the basic facts, it's the attendance in Sweden is around 75 to 80%, and in the lower socioeconomic areas, it's around 60%, so a lot lower. And what we've been doing is that we've been doing activities in those areas, talking to the women, their relatives, and informing about the importance of going to the screening facility. We have invitations in different languages, and right now we're running a project with bus and metro tickets for free to get to the screening facility. And we're really trying to get a higher proportion from those areas to come to the screening facility.
Yeah. Judy, do you have any reflections on this in terms of, you know, reaching these harder to reach populations and patient understanding of AI and how it's used and their trust in it, I suppose, as well?
Yeah, so those are many questions packed into one, and
yeah, sorry.
I love to hear what Karen said about what you know, the AI alone. And actually, before I answer this, I would like to ask Karen, do you think, as we've seen sort of like this multi-agent era, that what do you think if you had two different AI vendors? I know it's expensive and probably not reasonable to have two. What if you have a human and AI, but what if you had a human with AI A and human with AI B and AI A and AI B? What do you, I know it's a hypothetical question, but what do you think would have happened?
I think we would have different results, because the readers seem to be quite the same, because we're trained in the same way as radiologists. But for sure, the AI algorithms, they perform different. So I think the validation process is crucial for choosing which tool you should have in a special environment. So you cannot just...
yeah.
Yes.
I know we can talk about this like all day, but not trying to steal the webinar from Ben and Rupert. So I would say that when the patient perspective is something that we've been thinking a lot about, and it's a tough area, I'll just be honest. And number one, the reality, which would also be a question to Karen, like, why do you buy versus build, right? And there's quite a lot of debate about that. But when you look at patients, usually they don't have a mental model of what AI means in their healthcare context. And you have to ground it in something they understand. For example, you know, because we just use products, but you could say, do you use maps or do you use something, you know, this algorithm is sort of like the AI. And so when you sort of ground what AI is, what we found that that the patients have very varied. Are they willing to pay? So those are the studies that are coming out. Do they will? Because if it's not covered, do they want to pay for AI to be used on their study? This is very common, even like when you're getting the advanced eye pictures. Do they care that a center has AI or no AI? And you find very varied, I think, reactions. And what I'm saying is that this is an area we need to do a lot of work on, about what's true patient engagement and how do you do it in a way that is privacy preserving. Because we do know that there are bad outcomes for patients in any healthcare system. There are patients whose cancers get missed. And so do I go back and say, hey, sorry, Judy, we missed your cancer, but AI could have caught it, right? Or where the AI makes mistakes and is actually disparaging, how do we resolve that conflict between the radiologist and the AI system? And finally, how we use patients' data, I think, is an area that we have to disclose and really tell them, because the reality is when you're building your AI, you don't really know the downstream impact. And I'm saying this with just to encourage humility. You really don't know how the downstream impact is going to be for your product. And so if you're not really proactive in terms of telling patients, hey, this is what we're doing, here are the results, what do you think? And having them give feedback, I think we're missing an opportunity to really engage patients in AI. You know, and so most of us will try to do something, or you have one or two patients, but I still don't believe it's enough. And I come from the point of most we've looked at this recently with one of my students, that most of us don't have a framing of what AI is. And it even happens for the healthcare providers. And so that's sort of my reaction to sort of the last question.
Yes, can I reply?
Yes.
Yes.
Please take over. Me and Ben are not offended.
Yes. So it's really good points and good questions. And we also conducted a study about this, what the women's attitudes towards AI in the breast cancer screening program. And generally women or people have a higher expectations on products than on humans. And then we've also been discussing backwards and forwards of the responsibility. Who is responsible if AI is doing something wrong? Is it me, or is it my boss or the hospital? And we still don't have a clear answer about that. And I think the process with AI in the society is going faster than the regulations. So in Sweden right now, we really don't have a legal framework for using AI in the clinical environment. And then we have another complicated discussion about screening, because if you discuss, or women tend to think that screening is a perfect tool, and that is not. Breast cancer screening, they don't find 100% of all cancer cases. We know that for sure, but it seems like women, they're positive to having AI in the screening context, but with a human reader. I think we're not ready for AI only in the clinical setting right now. But these are questions that we really need to address, and the responsibility or the regulation system, we really need to have recommendations from different levels in the society. What do you think about that?
I think that, first of all, I don't want to, between evaluation and regulation, right? That this is something I actually learned yesterday, that we have to think about what's the difference between sort of regulation tends to be fit for use, right? You can use this drug, right? But when it comes to evaluation, really, I think it's almost saying, does this work for the task that I want? Or how do I, and that's where, you know, expecting that regulation is going to think about automation bias. I think it's stretching the regulators who also have to approve all these other devices, right? And if we separate that, this is an opinion, a personal opinion. If we separate that, then what you find is that evaluation should be local. Regulation can be global, and it solves this tension of the FDA or any other regulatory bodies not doing enough, right? In East Africa, where is my home, we wouldn't have the capacity to really do the regulation. It would take so long. And so I think that gives us a lot of freedom to start to say, wow, Karen, you published this paper almost four years, going to 5 years ago. What have you done, like in terms of real world evaluation? What have been the pitfalls, right? Those are the papers that are not published, right? And we want to know so that when I go to Emory or somewhere else, I don't make the same mistakes, right? And that gives us sort of that freedom, and also builds the evidence that is necessary for us to accelerate harnessing the power of AI, instead of everyone making the same mistakes. And we, you know, Rupa is going to reject that paper when we submit it till, you know, but these mistakes are happening, and it gives this flowery appearance that cannot be solved even by developing benchmarks or something like that, because the real world is just so different. And you know, and anyway, as you can clearly see, this area of regulation versus evaluation is very, very challenging.
Yes, I think that's a very good point, and to document and analyze the, so to say, mistakes or the errors when using AI only gives us gives us more trust in handling and using the AI algorithms in the proper way. So I think that could be the topic for many interesting articles.
Yes, I think we could talk about regulation and guidelines and for a long time, but I think maybe we could end with a little bit of future ideation on. We have a question about how we have so many AI models. I think, Judy, you mentioned this in your talk as well. A lot of AI models developed for cancer imaging, biomarker discovery, treatment planning. But what is actually going to be clinically useful? How do we streamline the selection for models that offer the most clinical utility? What do you think we need to be thinking about in order to really advance patient care using AI?
Yeah, so most of the work is showing that there's no clinical utility, and I think if I was to say for the next 3 years, what we should start to really work on, and this is the work that can be done by just bringing together multidisciplinary teams, is to really link metrics or AI performance to outcomes, right? Most of the editors now are saying, look, I don't want to hear about AUC anymore, right? And that it's not enough. And the reason why this is important is, I like to give an example of if you build something to predict heart failure, it's usually measured with an ejection fraction. And that's a number percentage that says your heart is working well. If it's high and if it's low, you have a problem. And this is such, what I would consider very a straightforward task. But most of our computer engineers and the journals, they don't really have journals, but where they publish in the conferences or on archive, they tend to look for beating the state of the art. Maybe that should be the work that we let the computer scientists do. But to bring clinical utility, I think requires new metrics, new clinical outcomes, and also patient-reported outcomes. And for example, in the case that I gave for ejection fraction, we should, it doesn't matter if you have an ejection fraction of 63 versus 67, nothing different is going to happen. And thinking about AI and the downstream consequences is much more important, and is a way also to overcome, this is a webinar about health equity, to overcome this inertia about what's a fair model, what's an equitable model, when we cannot all agree on what that fairness is for everyone, and so that linking it to clinical outcomes, I think, can leapfrog and say, okay, I can do this, early screening or palliative care is the one that makes the most sense for Global South. I'm not saying that the clinical trials are not good, they're expensive, but they're not available to everyone. But if you vaccinate people against hepatitis B, hepatitis C, and HPV, and manage HIV, you really reduce a burden of these diseases. And in palliation, when you manage people's pain, that they can eat and have a dignity in sort of the long-term illnesses, that's where you make, in my opinion, make the most bang for you, for the return on investment. So I think that linking to clinical outcomes and changing the metrics would be the first step, and then really compiling diverse data set. It doesn't matter if they're big, not for training. This also reflects a big change in sort of my approach, but for testing, because that's when we can really figure out, where is this failing? Not just training on diverse data set, but testing can say, okay, I see that this is not going to work for this subgroup of patients. And then you can decide what you want to do in terms of your deployment.
Answer. I love that. Thank you so much, Judy. Maybe we have one last question, and this can be a very quick one, but and I'm very sorry to everybody. There have been so many questions. We're reaching on 50, so that's been fantastic. Thank you for your engagement, and thank you to Karen and Judy for answering these. But this is the last question, which we can end with, and we'll go to Karen first. What are the top 3 concerns that keep you up at night with regards to AI and cancer diagnostics? So Karen, take it away.
Yes, so my wish and what I hope for is that we can use AI to diagnose women earlier. That is the key for downstaging a disease and to survive. That is one thing, and then also I would like more guidelines and regulations to get support from when using AI, and I think to get to get diverse data sets for training the models is really crucial to have a reliable output from the algorithms.
That sounds, I mean, that makes a lot of sense, making sure the algorithms help patients and ensuring that we have the right guidelines and regulations in place. And that's fantastic. And Judy, do you have a final answer before we log off this webinar and say goodbye?
So the three things keeping me up. One is there's too much hype from the tech companies, and there's a little bit of inequity. I remember this, some of the big tech people will say, oh, I can go for lunch and come back and I've trained a model. That's not a luxury that's afforded to everyone in the world. And I think that we need to figure out how to build capacity, think about where other more diverse people can be used, can participate in model development. The second one, I think there's a lot of enthusiasm around biomarkers from especially medical images like RadPath integration. But the challenge for those is that they are collected from clinical trial data sets. We know that are very strict, exclusive. And like Karen said, we'll need new data sets because those models are not going to work in the real world setting because they have very, very strict exclusion criteria. And I think that that's going to be a big disappointment. And then I'm still thinking about disparities. Why is it for a disease like breast cancer that has amazing treatment that there's still a subset of population that despite getting the same time of diagnosis of breast cancer, still end up with a poor outcome when there are already good treatments. We have to think more. We have to either use AI as a way for us to audit or figure out new phenotypes, but it's just helping you to step outside your technology to really say, why is it that everyone else got better outcomes, but the Black women, at least in America, still have very poor outcomes for even the most curable segments of breast cancer disease.
Thank you, Judy. That's a really important message to leave everyone with. Thank you both for your fantastic presentations, and thank you for answering all our questions. And thank you to the audience for bearing with us. And we've really enjoyed this. So hopefully we'll do it again soon. Thank you, everyone. Bye now.